Welcome everyone to the Cigarette Restitution Fund seminar series entitled Lunch, Learn, Link. This is the last seminar of our academic year. We will be starting up again in September with another dozen or so seminars, so I hope you'll put this on your calendar. Generally, we meet on Thursdays at noon, and most often in Sheldon Hall. So I'm glad those of you who came to Becton Dickinson found us here. And a special welcome to the folks in the audience. We will have some pizza afterward in the gallery, so make sure that you get a ticket, which I think you should get at that door if you don't get it before as you leave. And that'll entitle you to come to our pizza table for a little bit of lunch. And welcome to the online audience as well. We have folks who tune in while the talk is going on, and then of course we record it. So any of you who have colleagues who are not able to attend or watch at this time, they can look at the presentation later. So today we have a guest from School of Medicine, Department of Oncology, Ms. Dina Lansey. She's a wonderful colleague of mine working on clinical trials, and she's the one who really brings order to our clinical trial development, the processing, the reporting, the achieving goals, if you will. So Dina is a instructor of oncology and is creating a path of research into clinical trials participation. And her goal is to make more proportionate participation of minorities, of females, of seniors, of children. And so it's a big order, but at the Cancer Center, we can already see progress in this area, and a key component is data. So she'll bring some of her newfound information to you today. Dina?
Thank you. So if I only had Norma's introduction to go on, I would be completely terrified, because all I hear in my head is Dina, the peds oncology nurse who just happened to stay around for 20 years and ended up in the Cancer Center doing this work. But it's been an exciting role. It's a role I've been in for about 5 years now, and what I'll share with you today is just the approach we've taken in the Cancer Center to look at disparities in our clinical trial participation among minorities and women, how we are striving to meet the requirements of the NCI in terms of that designation of being a comprehensive cancer center. So it's lunchtime. So when I tend to do this, it's a conversational tone because I want you to think about your own experience in, if you're clinical and treating patients, recruiting patients to your clinical trials, or whether you've been a caregiver, a support person for a family member, because I think that is probably the way we need to come to thinking about barriers to participation in our clinical trials. So, is it okay? Okay. Oh, well, maybe it would help if I turned the mic on. Is that better? Yes?
Yes.
Okay. So we'll talk about what some of the barriers are as we see them in the literature. I'll share with you some experience from what those barriers tend to look like in clinical practice, and share at least one intervention with you that we've carried out in the Cancer Center to try to close that difference that we see in terms of demographics in our clinical trial participants. So the most obvious place to start is to make sure we're all on the same page about what a health disparity is. And impressive enough, it is the official definition introduced into public law in 2000. And I won't read the definition in its entirety for you, but what all of this boils down to is that it is a difference that we see in terms of incidence and prevalence, how people fare with their disease, how long they survive, how they respond to treatment, when we compare one population to the general population. And if we see a difference, it's considered a disparity. And to layer on to that, it's a difference that we shouldn't see. So in fact, if we have the mechanism to prevent, diagnose, and treat disease that we have deemed effective in terms of survival time, quality of life, and detecting those diseases earlier, then that should be true no matter who the population is. But in fact, it isn't. And what we see is that there is a difference in the incidence or that we see in certain populations compared to others. Some populations don't respond to the treatments that we have available in the same way, and they get to us later. So this is certainly not the exhaustive list of what contributes to health disparities. It's one that was appealing to me that I came across, and it was actually a list out of work by Tom Leviste, a former colleague here in the School of Public Health. And the first few bullets aren't surprising. Socioeconomic conditions, social and physical environmental factors, where you live, how you live, who you live with, what that place of residence gives you access to in terms of the quality of care that you get, and when you access that care, if it's culturally competent care being delivered. The two that piqued my interest and bought me this slide in the talk are the last two, health literacy and empowered healthcare consumers. Health literacy is interesting to me because I've always wondered whose responsibility is it? So when it shows up on a list where you are talking about the delivery of care or disparities in healthcare, whose responsibility is it if we evaluate potential participants and our patients in terms of their health literacy, that they are health literate? Should you come to me fully aware and understanding of your diagnosis, your treatment options, what clinical trials are, how they work? Or should I be able to recognize where those knowledge gaps exist and be able to deliver what you need to fill them so that you're able to be an empowered healthcare consumer and a fully functioning member of the healthcare team to make decisions? That empowered healthcare consumers one is interesting to me because I've seen it play out in clinical practice. I won't claim that I know exactly how to make a patient feel like an empowered healthcare consumer, but I know what they look like in terms of a visit with a patient. So because patients come to us from around the globe, across the country, an empowered healthcare consumer in a visit is the patient that shows up 6 deep with family members, a little wheelie cart full of information. And that room, when I've been in that room with a physician and me talking to the family, feels like an interview. They want to know, do we know what they know? Do we know it well? Do you know what everybody else in the country knows? And do you know everything that's in my wheelie cart before I even give you the indication that I'm going to let you take care of me? And they should. This should be a relationship that works well. You should feel that your goals of care are honored and respected, and that you are an equal member on this team to be able to make decisions about the treatment that you pursue. And when you're shepherded through that care, it's a match that works. And if it doesn't, that you go someplace else to figure out if it's better someplace else and come back. The balance of that room doesn't feel like that if you are, and these are real patient memories that I'm sharing with you, if you happen to come from 2-3 blocks away from the cancer center. You went into the emergency room thinking that you had a cough that wouldn't go away. You felt fine, you were at work, but now it's an emergency room visit. And you didn't get to go home like you thought you would. I'll get some antibiotic, I'll go home. You were admitted, and you ended up with a cancer diagnosis. And now we're seeing you a few weeks forward of that cancer diagnosis in the outpatient clinic, talking to you about your diagnosis and treatment options and how this is going to play out. There's no wheelie cart. There may or may not be family members or friends with you, and you don't know some of the things that that other patient came to us already empowered to know with that same level of health literacy. you might not necessarily know that you don't have to stay here to get care. I mean, we took care of you and you were admitted, we discharged you, and here's the follow-up. But you could go someplace else, and it should feel like an interview. But maybe that's not the way your healthcare has been handled to that point. So you aren't an empowered healthcare consumer. But again, it's the responsibility of those two last bullets that we get you there so that you can help to make decisions that fit your goals for your care. So when we shift to look at specifically clinical trial participation, it's preaching to the choir really to tell you the benefits of clinical trials, in that every new drug that we have would have followed the path of clinical trial work. But the US Census says that 40% of the life expectancy gain that we've seen in the past 25 years is attributed to clinical trials. But yet we have a participation issue in general, that only 2% of the US population participates in clinical research trials, and only 6% of those adults that have chronic conditions join clinical trials for those conditions, which is interesting considering in 2012, the CDC said half of all adult Americans, about 117 million people at that time, had at least one chronic condition. Hypertension, diabetes, obesity, cancer, heart disease are among those. And that 1 in 4 in 2012 had 2 chronic conditions. So the trials are happening. The new medications get approved eventually, because that pathway can be many, many years in coming from bench lab work to approval. But cancer trials aren't any different. The 3% is there. Probably more accurately at this point, it's somewhere between 3 and 8 is what we see in the literature, but participation rates are low. And of that tiny sliver of adult cancer patients in our clinical trials, a tiny percentage of those are minority patients. So one would wonder, if we manage to get drugs to the approval process and approve drugs and new drugs available that are effective, then should we kind of stay there and be happy that we can even complete them? Because it is a huge issue for clinical trials work that the funding is given, you open a study, and can you complete it? Can you keep meeting the targets that you need to complete the work and gather the data and move forward in those phases of trial work? But the bullets in front of you make the argument of why, even if it's a small percentage of folks that join those studies, why it's important that it's a diverse group of people. The no-brainer of we're not all the same. So some populations have a disproportionate burden of certain diseases, certain stages, a disproportionate benefit of what we find in those clinical trials, and potentially we end up finding out new things about the effectiveness and the toxicities of certain drugs because they weren't well represented in the studies that we completed. So ultimately, the health disparity gap, whether it's in cancer diagnosis and survival time or other chronic conditions, continues to widen. But we didn't get there kind of haphazardly. I mean, we essentially have a PR problem with clinical trials. The work gets done, the benefits are there, the US Census tells us there's a clear benefit to clinical trial work, but we're not great flag wavers for the work that we do. You tend to find out about clinical trials when you need one. So there wasn't much outreach work specifically from a person like me who's really doing in-reach in the Cancer Center to educate people about how clinical trials work. And when I started to go out to do it, the chances that you would be a relatively newly diagnosed cancer patient at the Northeast Market, stopping at the stall, talking to me, and in need of therapy, I may as well play Powerball, because the odds are a little bit more in my favor that I'd do that than that person would happen to show up in the market for me. The people that did show up in the market, who I miss very much talking to, Barbara, are those folks that could tell me they've had hypertension for 20 years. They've been taking the same hypertensive for 20 years and getting up peeing in the middle of the night for 20 years. Have you ever had a discussion with your doctor about maybe a different drug, a clinical trial for a drug? Here's this general information on how this would work, and you have no idea what to ask him or her. Here's some questions on the other side. Has nothing to do with clinical trials in our cancer center. But if I can tell you about clinical trials in general, I don't really want to see you in my clinic because that means you now have a cancer diagnosis. But I'd love for you to know, as a support person, as an empowered healthcare consumer anywhere in healthcare, that they exist and what you should ask and consider when you make a decision about joining one. But there are lots of misperceptions because we don't do that positive counter work so well. And these are some of the things that we hear that people think about clinical trials. If I do not agree to join a clinical trial, I may not get the care I really need. I can be enrolled without my permission. If I'm in a clinical trial, researchers might intentionally make me sicker as part of the experiment. Or that last one that essentially, if you're in a clinical trial and given a treatment as part of that research, that a more effective treatment might not be given to you because they'd like to keep you in that clinical trial. Sounds crazy if you do the work, but is it that crazy? Because all of those statements, if you know bits and pieces about some of these cases, walk back to there. So can you be enrolled without your permission? Can you somehow be coerced into, I have a treatment for your child, and you need help with a child that you're unable to take care of anymore at home? Oh, but the beds that we have available at Willowbrook are only available on the wing of the the wing of the institution that are carrying out a research study. So if you sign to participate, we've got a bed for you. Or could you be in a study and not be made aware? The Jewish Chronic Disease Hospital with the elderly and researchers trying to see how cancer cells played out in the progression of cancer. And with Tuskegee, the one probably most familiar to us in that there's an effective treatment, but it was withheld so that we could complete a study that we set out to complete. But the years on the right side say that none of these things happened that long ago. So even if you don't have all the details of these cases straight, bits and pieces from them directly support the misperceptions that we just listed. But after each of these took place, the research community did something in response. So, we would all wish if we could get in the Wayback Machine that they never happened, but they did, and what do you do in response? So Tuskegee, the Belmont Report was after that, and it established how we would protect participants and what we could and couldn't do, and risk and benefits and justice and beneficence. It's all there for us. But I don't know that we did a good job in explaining what those things meant and how they really did affect how we carried out research moving forward of 1972-73 with the Belmont Report. But we've covered the benefits that trials have, reasons folks might not join studies, and the importance of diversity, but people didn't just start to come. So we have protections in place, and really the goal of all of the protections outlined, guided by the Belmont Report, ended up being the protection of vulnerable populations, women, children, minorities, prisoners, potential women with the potential to become pregnant. But then there was this shift in the late 80s, early 90s around HIV and AIDS, and it's credited to women's rights groups, who then became really upset that you're protecting me from the ills of research, but that means that justice has a different meaning in that I have no access as a woman who's HIV and positive and pregnant of joining any studies about AZT. And at the time, it was the most promising thing on the horizon for anybody with HIV and AIDS. But those studies were predominantly study slots filled with gay white men. It is who we thought we were to focus on. They actually found a champion in Ted Kennedy who worked with them to come up with what was ultimately signed into law by Bill Clinton in 1993. And some of the bullets before you are the ones that are outlined in the law and eventually put into NIH policy guidelines that essentially says that if you receive federal funding you are bound to ensure the inclusion of women and minorities. If they are not included for any reason, that you have to specify why they're not there. So I'm an investigator, I have a prostate study. I need to still answer the question, and I have to say, well, women aren't included. Women don't get prostate cancer, but I have to have some response to why they're not represented. And I have to have a plan to say, how's the study going to be designed that supports answering the scientific question, but also supports the inclusion of the populations that should be well represented in the study? And what's my plan for outreach and recruitment? So before you even get started, you can write in the language that tends to get copied and pasted, that women and minorities will be equally recruited and included in the blah, blah. How? How will you do it? And if you are failing to meet your targets, because these policies actually include language about IRB review and continuing review of any study. If you've missed your target, then what's the corrective action going to be in terms of outreach and recruitment? So we have benefits, we have misperceptions, we have things that are in place tied to money, which usually work, that if you tie it to money, people kind of get going. But still, the people didn't come. The women's rights groups got access to the studies that they most wanted access to, and they changed things for all potential participants with the finalization of public law requiring their inclusion. But then work needed to be done to say, if we know their benefits and we can say what they are, by federal law, women and minorities have to be included, but they're still underrepresented in the same studies that are getting federal funding. And what is in front of you is the list of barriers that show up in the literature that gives us some basis for understanding why women and minorities are underrepresented in our studies. And what I'll challenge you to think about as we go through these is that maybe our consideration of these barriers has been too narrow. And if we think about them a little bit differently, maybe we'll be able to come up with interventions that are different and potentially more effective. So fear and mistrust is always there, and it should be. And if you're reading an article about African American patients, participants, and fear and mistrust, 3-4 lines later, you'll find Tuskegee. You can just do the word find. But if we limit our thinking to African American participants are leery of joining a clinical trial because of Tuskegee, then we let ourselves off the hook a little bit, because we're not going to be able to go back and change anything about what happened then. But if we consider fear and mistrust could be many other things, and we'll look at those, then maybe we would be effective in the African American population and many others. Access, language and literacy, researchers, and structural and organizational factors. So individually, there is a historical component. There's a knowledge deficit about what trials are and how they work and how you're protected. But is there also the potential that there's an issue related to fear and mistrust about the medical profession as a whole, healthcare as a whole, the history of the institution, and whether or not a particular community feels well cared for by that institution or has a good history with that institution. How many are from Baltimore? Here. It's always a tiny number, but I usually want to know. And I want to know because I'm from Baltimore. So the history of the institution and the community that they sit in means something to me. My mother was from East Baltimore. So the story that most hear, whether you're from here or you get here and somebody tells you almost immediately, is that the community believes and has, the story that gets told is you don't walk through the Hopkins campus after dark because they snatch people off the street and experiment on them. Right.
It's been told forever.
It's been told forever. Your forever, my forever, and neither of us are old enough that you would think that's really our grandmother's story.
Yeah.
But it's not even the best story that I heard growing up about Hopkins. But it feeds into whether or not community members believe that story and ultimately make the decision to receive care here related to that and other stories. My mother's family was all kind of grew up within a couple blocks of here. Most of those blocks aren't houses anymore. They are the Hopkins campus. There are serious feelings in the community about this march we're doing to North Avenue with this campus. So, does that play into whether or not you want to receive care here? So those of you in the room, whether from Baltimore or not, if you remember Church Home Hospital, it wasn't always our HR place. It was a real hospital. As a teenager, I even thought it's like a death trap. Like, who would go there for care? Every one of my mother's first cousins would walk through this campus to go to Church Home. So they make that decision based on who they believe we are as an institution and their experience in having ever received care here. So if they ended up in an emergency room here, were they treated well? Were they treated as if they weren't smart enough to get it, they didn't have the means to have an exchange there? Or did they have bits and pieces of a story of, oh, Mr. Jones, who lived 3 doors away, was healthy as a horse. He worked every day. He's like 800 years old and still working. And he went to Hopkins, and 2 weeks later, he was dead. As my grandmother would say, dead as a doornail. Yeah. So it was their fault. Yeah. But if that's the story that you hold on to, then you're probably not coming here for care. And then none of those have anything to do with Tuskegee. Access is a list that would have been one bullet before the Affordable Care Act, because we focus solely on insurance. Did you have it or didn't you? If you had it, did you have a clinical trial benefit? If you had a clinical trial benefit, did we spend a month arguing, trying to win an appeal of a no that would say you should be able to join this phase 1 study because your carrier said that they would only approve participation in a 2 or a 3? But access is really all these other bullets as well. The availability of trials. So what does our portfolio of studies look like in the Cancer Center? Do we essentially have a trial available to offer to pretty much every patient that we see? So across the range of stages, prior therapies, performance statuses, comorbid conditions. I mean, do we have a portfolio that would pretty much let me as a provider have a clinical trial available to who I see? And if I do I invite them equally to enroll? And when we look at eligibility, so if I have a great portfolio, I've extended an invitation, but does the inclusion-exclusion criteria exclude certain populations because we didn't go through it with the thoughtfulness that that eligibility checklist is kind of weeding out certain groups? So if I have a phase 1 study, it's done safety-wise on the inclusion criteria. I wanted a totally normal blood pressure and a normal serum creatinine. But I didn't see much toxicity in either. But I moved that inclusion-exclusion criteria forward with my phase 2 protocol write-up. But if I want a totally normal blood pressure, there are groups of patients that I'm excluding. Maybe you have been hypertensive for some time, it's well managed, but you are either not going to be eligible because it's not totally normal and I'm not given a window in that inclusion criteria, that exclusion criteria, or because of a drug that you're taking which could also exclude you. And if you're well managed, you fall within the blood pressure range, your serum creatinine after years on your medications is probably not totally normal. So do I have a window there? And if I don't, does that kind of outline what could be an African-American man who was interested in a prostate study that I have who's now deemed ineligible because his blood pressure is not totally normal and his serum creatinine is not totally normal? So to give some more thought to what our eligibility criteria look like and to really carefully consider, does it all need to be there? Am I being safe because it is a safety issue with the blood pressure or maybe kidney function? Or can I offer some window in there to accommodate patients who might otherwise be deemed ineligible? And the final one is participation requirements. What are we asking folks to do? And do we really need to have them do it at the time points that we've written into a study? Do I have to see you 10 times in the first month of treatment? Or can I have you do your quality of life study at home? Can I have that single blood draw added to a visit that you're already here for? Because potentially you're going to turn me down because you can't get here 10 times in a month and take time off from work or come within the hours that our clinic is open. So carefully thinking about what we're asking patients to do, when we're asking them to do it, and if that in itself could pose a barrier that says, okay, I'm interested, but I can't do that. Researcher factors, I won't spend much time here because lots of this gets covered in other places. Cultural competency is all the rage. Everybody talks about cultural competency. I don't know that anybody has come up with any education tool that I've seen to this point that makes me confident that anybody that did it would be culturally competent. And should that be the goal? Should it be, here's this online education requirement, you do the course, now you're culturally competent and the full staff is? Or should it be culturally aware? And should we be able to do that in ways that kind of keep people thinking about who they see and who they bring into the room to see the patients that they're seeing? And how aware are researchers and medical providers of what the barriers are and what they look like in clinical practice? Provider bias is the one that gets the most attention here. And generally, it shows itself in work that people are trying to figure out whether or not it's a discordant pairing, white physician, medical provider, and a patient of color. Is the offer extended or not? What's the dynamic of the relationship there? But I really think as we go through these, there will be other things in terms of provider bias that it doesn't always come from a negative place, but it could certainly end up in one. And an example of that for you is cancer patients are living a lot longer. It is a chronic disease at this point. So think about a patient we've now taken care of for 5 years. It's an African-American woman, breast cancer. We've treated her, she's recurred. But now we've had the privilege of taking care of her for 5 years. So I know she is a single mother with a teenage son, the grandchild that she's raising, and her work is tough. So she doesn't get paid if she doesn't go to work. And we are having a discussion, the medical team, the research team, about a trial that's potentially available to her. But it is that one that is 10 visits for the first cycle of treatment. And the physician says, you know, I don't think we should offer it. Like the burden, why would we put that kind of burden on her when it's pretty much all she can do to get here to remain compliant with the treatment that she's receiving, the standard of care at this point. So maybe an offer isn't extended. Now, if I was in that room, I probably would have just jumped on his back, mad that you would withhold the offer. But where that scenario actually ended up coming from is a small interview study that I did to ask our providers when they choose to or how they decide to extend an offer. Is that decision making different? Do they consider characteristics about a trial before they extend it? And if all of those conversations, is it different if it's a minority patient or not different? And a quote from that study was a physician saying that he didn't think that it was a racial issue at all, that he thinks it's an education issue, a socioeconomic issue, and that sometimes minority patients are more concerned about the potential of being a guinea pig or the burden of a clinical trial, that their focus doesn't tend to be one of an altruistic point of view about clinical trial participation. So sometimes he doesn't offer it, but really weighted towards not wanting to layer on burden. Well, that's an interview study, and it took quite a bit for me to not jump on him from, I'm thinking he's really saying this. Like, this is not, so we talked about a patient that is that African-American breast cancer patient that we shared a few years prior to me taking this role. And I asked him, did you know, because he knew about the teenage son, he knew about the grandchild, did you know that at any point that she came to visit us, you could have gone out to her van, her raggedy, pray over it that it's gonna start van, and you would find non-perishable food and crocheted blankets, all of which she crocheted, because she drove around giving them to people that she knew needed food and needed blankets. You're out of heat, I'm gonna help you raise money. she's all tapped out in terms of altruism, but it's someplace else, and now he's made a decision that that might be a patient that he not offer a trial to. So do we need to consider provider bias in a way that is not so obvious as I'm not going to offer this to the elderly patient, the poor patient, the minority patient, that there's some other factors that come in there. Now, he prevented me from jumping on his back because he didn't know some of those things. He's coming from a generally good place that I think I know her well, and I don't want to overburden her with this, but he's also taken away her right to choose and figure out whether or not that trial was suitable for her. Structural and organizational factors are these, how does your research team work? Who talks to them first? Who do they see first? How many invitations to join any study do they get before they end up in the room with the physician for a visit that they have been waiting a couple weeks to get? Have 4 other people talk to them about the biospecimen? Can we get an extra tube of blood? Can you do this quality of life survey? Can you? By the time they get in the room with me, they just are happy to be able to say no to anything. And I might be the no. So to give some thought to what a patient actually sees from their perspective in a flow in your clinic, or when they come in, if they're healthy volunteers, if they come in to talk about a study. What is the ask? How many asks are there before they kind of get to a point that they can really make a well thought out decision? What I will share with you from this one is that how we as providers and research team members lose sight sometimes of what we see and do every day. Like, you don't even see it anymore. The rush into the Weinberg building to our outpatient clinic, I've done that walk for 10 years. And it didn't dawn on me until I was doing this work and thinking about some of these things that I walked in the lobby, past admitting registration, gift shop there. The lobby's pretty nice looking. You go into a waiting area that has far more people in it than you wish it did, and then you end up in the rooms where the consult rooms are. And then it dawned on me, I have not seen one visual that says clinical trials is a part of who we are. No poster, no flyer, nobody wearing a button, nothing. So if you end up in the room with us and we start talking to you about clinical trials, have we made you aware in the mailings before your visit, during your wait in the waiting area, you're going to have a discussion about clinical trials. Even if I don't have one available to you today, you're being seen in a comprehensive cancer center. It is part of who we are. So whether today or tomorrow or 6 months from now, somebody is going to ask you about a biospecimen study, a quality of life study, a therapeutic treatment option that is a clinical trial, but we didn't tell you that. So then have we laid the groundwork that you are sitting in that chair wondering, does he offer these to everybody? Or is it just certain patients? And if it's not something they do with everybody, that would be why. It's not well advertised in the cancer center. So we needed to think about who we look like we are as a cancer center, and clinical trials weren't represented there. So who fixes it? I mean, essentially, of the barriers that we went over, whether you are a community health worker and a navigator, a research coordinator, a research nurse, a physician scientist, it's everybody in the pool. Everybody has some potential for influencing what the diversity in those trials look like by addressing the barriers in a broader way. But to share with you how we are held accountable as an NCI designated cancer center, this language is that those designated cancer centers are responsible for carrying forward cancer science and being able to establish what standard of care becomes and sharing best practices with cancer centers across the country and around the world. But we're also held accountable in terms of outreach and establishing those same standards in terms of diversity and participation and disparities. So the NCI uses a couple ways to evaluate how well we're doing or not doing in that work. And they first ask that you tell them who your service area is. Where do your patients come from? So ours can come from all over the place. they want a more refined, you need to be able to define a geographic area for them, because and ours is Maryland, and what that area looks like in terms of demographics. And for Maryland, in really broad percentages, it's 60% white and 30% African American. And the expectation of the NCI is that you service your immediate neighborhood of your campus as well as you do your full catchment area. So for us, that is specifically East Baltimore, but it is Baltimore City proper, where the demographics are a mirror flip-flop of the state. It's roughly 60% African American and 30% white. So just those broad percentages, you know that the approach to be able to address what diversity and inclusion looks like among those two different areas of the state might be very different. So the NCI wants to know, when they look at the inclusion of women and minorities, is who is the cancer center's population? Does that reflect the catchment area? So the number they actually look at is the state cases of cancer. And of those cases of cancer in the state of Maryland, how many come here for care? And then how many of those go on to your clinical trials? And what they want to see is the demographic breakdown of those two groups. So in your cancer registry are patients you diagnose and treat, and the demographic breakdown of those folks. On your clinical trials, the demographic breakdown of who joined a clinical trial. The difference between those two by group. So if your cancer registry says you diagnose and treat 19% of those patients are African American, when they look at the breakdown of your clinical trial participants, they want to see that 19% of those are African American patients. The difference between those two percentages is the disparity. It is the gap that they call, and they'd like to see that be zero. And I'm standing in front of you because it was never zero. And I don't think it's been zero in any cancer center that has a truly diverse catchment area, but their definition of what their catchment area is might skew what those numbers look like. But that path that I just described for you, so is above. If you're outside the cancer center, did you make the decision to receive care here in this cancer center? And if you did you ultimately end up on a clinical trial? So I would be standing in front of you with all white hair if I had to solve the disparity issue across the full pathway. But before we get there, to layer on the barriers we just talked about with that pathway in mind, they could look very different depending on where you are. If you haven't even made the decision that you'd like to receive care here, so my mother's family and all the cousins who wouldn't come for care here, that basis, where your fear and mistrust is rooted, is different if you won't even come through the door. But if you came through the door and you just don't want to be on a clinical trial, my approach to that fear and mistrust, or the approach I take in terms of education about clinical trials, is different and should be. But you have to focus. So the examples of the interventions that we tried were focused inside, because personally, it felt like a more egregious thing that you couldn't provide what you needed to or should to patients who have already decided to receive care here, to allow them to make a decision about whether or not they wanted to join a clinical trial. You have it, you know it's promising, say no if you want to, because since none of you are from the cancer center, I can tell you the joy of doing the work wasn't in how many said yes. It was, if I give you everything that you need to be able to make an informed decision and you still say no, then I'll pack up my little stuff and leave when the NCI goes, because it would have been approaching that work from a perspective of a clinician, a peds oncology and then an adult oncology nurse who recognize those people aren't that different. They all generally want the same thing. They want to fight a good fight, live another day to be with the people that they love, and contribute to help somebody so that they don't necessarily have to follow the same path they did. But that speaks to the fact that in addition to those barriers, there are all these other factors related to an individual patient and the individual providers that affect how that pathway to a trial plays out. So it isn't just about the barriers that we've covered. It's who's in the room. What is their language and communication skill, their income level, sexual orientation, their political views, what's the dynamic of their family, and what's yours? Because you bring you in the room too, and that's where provider bias tends to show itself. You are who you were before you open the door to do a patient visit or a recruitment visit, and to be mindful of that as we consider a pathway to a clinical trial. And this is the stages of clinical trial enrollment. It is actually work by Norma Kanarak, who's here with us. And in those boxes above, it is the path from a patient being seen to ultimately ending up on a clinical trial. The circles on the second row are all the potential places they could fall off of that pathway. And when Norma initiated this work, it was to understand who they were, who ends up being seen and ends up on a clinical trial, and who falls out. By demographics, who are those patients? For me, these are all clinical, physical locations. I know that at that point that this work, we started this work together, that patients weren't being pre-screened. I know who's looking at eligibility before they get into the room with the physician. I know which physicians are talking to those patients and what their pattern of trial discussion is. Is it part of their new patient spiel? And they talk about clinical trials whether they have one available at that point or not? Or is it a physician who never talks about them in that first visit if he or she knows there's no available trial today? And if they fall out along this path, who was interacting with them? Research nurses, coordinators, what information we collected. And a retrospective look at that work, Norma's original goal to figure out who those patients were, resulted in a retrospective review of medical records of 688 breast, prostate, non-small cell lung, and pancreatic patients to find the common reasons for non-enrollment. That it was an availability or an eligibility issue, the distance from their home to our cancer center, they preferred standard of care, or they just chose to receive care elsewhere. And when we looked at disease programs by comparison, we could even see differences in who discussed them. It wasn't easy news to deliver, but we met with the prostate group and the upper aerodigestive group to say that when we looked at the medical records in that retrospective, 80% of the prostate patients had a clinical trial discussion, but only 53% of the non-small cell lung patients had a clinical trial discussion. You have to know the lung folks were not happy for me to deliver the news that, so it seems, the prostate physicians are all better at and more compliant with the thought that every patient should have a clinical trial discussion. And the argument was, of course I talk about clinical trials to my patient. But if you are a clinician, nurse, or physician, you know that if it's not in the medical record, it didn't happen. I don't care if you stood on your head talking about clinical trials. If you didn't put it in your note that you had a discussion, that's how we ended up with 53% of the non-small cell lung patients not having a discussion. And it could be a very good reason why. And I could have walked in some of those rooms in the past with some of those physicians who were now pretty pissed off that I said prostate was better. Not that that's what I said, but by the percentages. And it is a room that says, okay, medical records when we were in paper charts, that doesn't date me at all, right? We've reviewed the chart. These are the potential studies. We are now leaving the provider area where we hang out between patients and review records. We're walking up the hallway, oh yeah, study number 1, 2, 3, 4, and this other one, we'll talk about that with the patient. You go into the room, and there is the patient in a wheelchair, on oxygen, half asleep. That's not the patient we just read about, whose medical record goes through 1 month ago, who was not in a wheelchair, not on oxygen, and now all thought of those 2 studies is gone. Because that patient that we see in the room is not going to be eligible by performance status for either of those 2 studies. So consideration of those studies happened. Clinical trial discussion didn't, and it didn't make it into the medical record. So it wasn't the practice of that particular physician to document in his note, studies, blah, 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 these two potentially available patients' performance status would make them ineligible. It's not there, so it didn't happen. So we thought to do a prospective. What can you tell us about the people that you talk to about trials, and what's the easiest way to document that with you guys? So it generated questions for me in trying to make sure that we met our target recruitment for minorities and women, but by asking questions about patients that we didn't have records for. Who are we talking to? When do we talk to them? What are we saying to them? What do they say to us? And are they enrolling? So it falls on this end of those reasons. They fall off. 3 years forward, that's a database of 3,200 patients that had a clinical trial discussion and didn't go on the trial that was discussed with them. That means that, we already know that there are patients that get multiple trials discussed with them. If you see a patient today, it's a prostate patient, there are physicians that's routine practice, there are 3 available trials, I'm giving you all 3 consents, I'm telling you who those research nurses are, they will contact you, you review the consent, talk to your family about it, come up with questions, she'll answer them, and as the physician, I'll see you in 3 weeks. We'll do the same thing with the questions that you have and make a decision about your treatment. So maybe they declined 2 and went on 1, but that's why the database is actually such a large one at this point. And the reasons that are in there kind of track along with Norma's reasons in the retrospective, that people weren't interested because it's too far from home. They had privacy concerns, preference for standard of treatment, or that it was too many visits and too time consuming. They sound different in that database, but they all walk back to barriers we're used to hearing the names of: access, education and awareness, fear and mistrust. So that alludes to the fact that we could probably do something about them if we know specifically what people are saying or their reasons for non-enrollment. On your left, you have the demographic breakdown of some of those reasons that were put in to our database, and on the right, there are free text entries that research teams could make when someone declined and said they weren't interested. Specifically, why aren't they interested? The preference for standard of care was there. A design issue that there was concern that there was a randomization or inclusion of a placebo, or that they were just generally not interested in any research treatment. The others, some of the most common reasons for other as a non-enrollment reason: finances, distance from home, and cost. And the final one, most folks were not eligible in that database because of comorbid conditions or the declining performance status, like the patient I mentioned being seen with a lung cancer diagnosis. But if we work back from the reasons on the right, we were able to develop specific interventions that then targeted reasons our patients told us versus walking towards an intervention that we are trying to address a barrier that we see named in the literature. So we developed clinical trials education videos to specifically address concerns about randomization and placebos and the preference for standard of care. It's not new information, but based on what our patients told us, and an advisory group of patients, family members, and community members, we developed videos to deliver that information in the way they wanted it, and to specifically tease out the reasons that they said concerned them around design issues. The transportation study wouldn't address all of the financial constraints that somebody might face if they joined a clinical trial, but it was one that was available to us, so we developed a transportation study because parking on this campus is expensive. So to go back to that example of some clinical trial that has 10 visits required this month, can easily rack up to about $120 in visits for parking, because I think the max a day is around $12 or $14 a day. So those candidates, as long as they sign the consent for the transportation study before they make a decision about the therapeutic trial being offered to them, will pay for the parking. They can come in 10 times and talk about the study. They can move to consent for the therapeutic study, and for all of those screening visits, we'll pay for the parking. And if they enroll after they're deemed eligible, we'll pay for parking on that study for up to a year. And if they progress and go on another one, the clock starts over. And you don't care about any of that if you live in Baltimore City and you don't have a car. So there's an arm for Baltimore City participants. And those candidates could choose between parking or yellow cab transportation. And the time frames are the same, but we'd send a yellow cab to come and get you so that you could get to clinic visits. And that too would go up to 1 year. So where did we end up? African Americans actually have been the focus in terms of minorities for the demographic reasons that I showed you for Baltimore City. And where I'll show you that we ended up is in 2010, this grant with the NCI is reviewed every 5 years. So back in 2010, what you have in front of you is the line with the diamonds is our cancer registry, so those patients that we diagnose and treat. The red square line is the one that is the percentage of African Americans enrolled in our clinical trials. And the green line is the disparity, so the difference between the two. So in 2010, for interventional studies, African Americans represented 14.6 of those participants, but they were 23.1% of those patients in our cancer registry. So the difference between the two at that time was 8.5. And the difference between the two when the NCI came back and confirmed I could keep a job was 1.8. For women, we saw similar changes. In 2010, the difference between the percentage of women in our cancer registry compared to the percentage of women in our clinical trials, that difference was 7%. And when the NCI returned for the next grant review, it was 2.1. These were differences, and when we looked at therapeutic trials for African Americans that hovered around 11.5% for 20 years. And I don't have the magic wand I wish I could claim I do, but I think there are many reasons that we were able to close that gap so significantly. The approach was different. We increased awareness of what the barriers were, that it was everybody's responsibility to address them. We made sure that individual investigators and research programs had the support at a cancer center level to be able to improve their recruitment and the diversity in their recruitment. And we had some uncomfortable conversations with folks about race in Baltimore City. And it kind of normalized being able to expect to have those conversations without, you're not meeting your target, you're not enrolling minority patients, that there is something wrong that you're doing. What could we change? So there was a shift in the culture in the Cancer Center. So I'll leave you with a couple thoughts, and that is the literature is a great place for us to start, and we need that work to continue to march forward, but it needs to be a dynamic relationship between the two, that the literature should inform and guide some of the interventions that we put in place in practice, but we need to be able to feed them back the other way. And there should be things that I see happening in clinical practice that I should be able to work with colleagues here in the School of Public Health and the School of Nursing, as we do now and didn't back in 2010, to be able to get answers to questions that we need. And that we understand barriers don't exist in isolation. If you have a fear and mistrust issue, you potentially have a social support issue, an education issue, and what we know is those things aren't really defined and determined by race. It actually is more of a socioeconomic issue. And when we consider Baltimore City, black or white, if you live in Baltimore City, you are less likely to go on a clinical trial that we have available for you than somebody who comes to us from outside Baltimore City. So it's not a race issue there, but there are lots of issues surrounding being a resident of Baltimore City that could play into why you didn't end up on a trial for us. So there is no one-size-fits-all intervention, but a very fluid relationship in how we look at them and how we work with each other to close that gap. Thank you.
Thanks so much, Dina.
Thank you.
Questions from the audience? We have some time.
Very nice presentation.
Thank you.
You touched on it, but it seemed to me, as I was thinking about this, and people I know who've been in trials, that loss of time and loss of money seems to me to be high on the list. And I know you mentioned it, but it was among many other things. Is there any research, or have you done any work on like the benefit, how many more people you get volunteering with escalating offers of remuneration? I mean, I know a lot of times it's just, well, we'll pay for your transportation and parking costs, but I think
And you know, that one.
you really need something a little more than that sometimes.
You need more. I'll agree with that. I think even the offering of transportation is light years easier, it seems, for industry studies because first they have the money, so they tend to include it in their budget. When we tried to do this transportation study initially, the IRB application got tons of questions related to coercion. So I think that's a barrier in terms of being able to address what we know are obvious financial constraints. What I wish I could pay for is childcare. I wish that there was some leeway for different clinic hours. So yeah, you can go to work because the science has gotten us to a place where many folks after diagnosis and throughout treatment could go to work. But if I need you here and your goal in terms of your hopes for your care says that you're going to join this trial, now you've missed this much work. I think we don't, so I don't know what the literature says about incentivizing and do we see some difference in participation rates. I think the work that interests me most at this point that has to do with the financial reasons, are there more people looking at the financial toxicity of cancer care in general and then clinical trial participation? We didn't ask the questions. We didn't ask if, as a research nurse, it was something I realized I did as well. If I told you you needed to come 10 times this month, I might be going over the consent and I'm saying, okay, so that means it would be 10 visits next month. I probably didn't follow up and ask you, can you get here? How can you get here? Can you pay for the parking? If it was a study that paid for parking, then I'd probably tell you it's 10 visits and, I'll give you a parking voucher for each visit. But those financial toxicity studies are actually going at a greater, more potentially beneficial level of detail to ask about missed time from work, childcare, ability to pay household bills, if this, if that. And I think that's really interesting work to try to figure out whether or not that should shift what we offer in terms of support services and how well we know what's offered in the community. We don't have a cadre of patient navigators in the cancer center. But when I met some from the University of Alabama and found out that in their intake, they even asked the patient what church they belong to. And I thought, oh, well, that's nice. No, they're not asking to be nice. They're asking because they know specifically which churches in their community offer rides to visits, make meals, have companion programs so that people don't have to come to visits alone. So that means the spouse or the mother or the son or the daughter can go to work. But they ask the question and they know exactly where to connect them to tap into those resources. And that's not something that we have. I haven't packed to go to Alabama yet, but they have a spectacular process for understanding what's offered in the community to offset those financial constraints.
Is there a question here in the middle?
Yeah, I don't need the microphone. My voice is loud enough.
If you don't mind, use it. Because we're recording. We want to capture.
I just had a question upon, did you see that the fear and mistrust was lower when the patient and the physician had a common, were from a common minority group or race or whatever?
I mean, I haven't. And I will tell you that's just by virtue of the lack of diversity in our cancer center. That's not something we want to, we're not, but there was no opportunity to, and even if we thought that was the issue, I didn't have enough African-American medical oncologists working with me to think that we could even approach that potential issue that way. or enough African American research nurses to do that. And quite frankly, my fear when I took what was my dream job to do this work, I didn't know how to fix it. I just wanted to. But my fear was, okay, now what if I take this job and the whole plan for the cancer center is whenever a brown patient says no, send Dina in to talk to them. Then I'm the brown closer. That's not work. That's not life's work. That is me doing what I and all of my individual cockiness for loving the work that I'd done all that time in the cancer center said, yes, I know how to talk to patients of different backgrounds and because how many times had a physician left the room and a patient looks at me and says, what did he say? So if you can translate that, you feel a little bit empowered to be able to bend what you say and how you say it and still get to the same end point because you are aware of who you brought in the room with you. But I'm not the literature says that some of those clinical trial decisions, those decisions are different when patients are in the same race. There are focus groups and survey work that says patients say that it is different for them when it is a healthcare provider of the same race or sometimes gender. I am not a proponent of that thought because this work needs to be done in a cancer center that lacks diversity as well as one that is diverse in communities they themselves that vary. So the goal should be to teach everybody to be able to figure out who you're talking to and what they need versus getting done what you know has to be done. So I know an informed consent has to be done, and I worked with a nurse for many years who her process was to read the consent form. 5 pages, 13 pages. We're reading it because she needs to make sure you've heard it and that you've made an informed decision, and that's how she did it. It's not wrong, but I'd be asleep by the time she read a 13-page consent to me, or half asleep by the time she got to the thing that was was nagging me about the decision. How many times, how much time away from work is there? If that's what you want to know, you're zoned out for the first 10 pages. So you need to know how to assess what the need is and meet it versus making sure informed consent is done by reading the consent form or whichever.
Well, thank you, Dina.
Thank you.
We'll adjourn to the gallery for pizza. It's out here to the right. Let's thank Dina.